Hi there, I'm Jamie Taylor. Welcome to Your Health Matters, brought to you by Kingman Regional Medical Center, your community-owned hospital. This program focuses on different healthcare issues and services provided by KRMC. I think it'll be of interest to you and your family, so stay tuned. We'll be back right after these messages. Welcome back to Your Health Matters. My guest today is Mark Hopkins. He's the supervisor of KRMC's Sleep Disorder Center. Did I get that right?
You got it right.
Oh, good.
Good to be here. Good morning.
Thank you. So the Sleep Disorder Center is kind of a new name because we used to call it the Sleep Lab.
Yes.
But now something new and exciting has happened to change the name. Tell me about that.
It has. We've recently became accredited by the AASM, that's American Academy of Sleep Medicine.
Oh, very good.
As a full comprehensive sleep disorder center.
Very good. So what does that mean exactly? I mean, what separates it from a sleep lab? What makes it different?
The AASM does accredit sleep labs, and how they differentiate that is the sleep centers are taking the full spectrum of sleep disorders, whereas the sleep lab are kind of limited on their ability to treat certain disorders. We can treat the full line
Gamut
of sleep.
of it all.
Exactly. And also we have board certified sleep specialists. Dr. Haven Malish is our director.
Yeah, he's been on the program before.
Yes.
Dr. Malish has been.
Yes, he has. And Robert Matheny. They're both board certified in sleep medicine.
Okay. So obviously then from what you just said, there's many different types of sleep disorders. I always thought you either snored or you didn't, but there's more to it than that, right?
Quite a bit more, yes.
Okay, so let's talk about that. What are the different types of sleep disorders?
Oh heavens, there's the National Sleep Foundation has outlined 85 different sleep disorders.
85?
Yeah.
Oh my gosh.
So you would think just snoring, sleep apnea, it's just a small fraction of what's happening out there in the sleep field. There's parasomnias, there's REM behavior disorders, there's jet lag, leg jerks.
So all that stuff is going on while you're sleeping?
Yes.
And that's why they call it sleep disorder, right?
Yes.
It impacts your ability to sleep?
Absolutely.
Okay.
Yes.
And you have the rest that you get when you're sleeping.
Yes.
So, and I guess I've known that there's like, it's narcolepsy? Is that right?
Narcolepsy.
Narcolepsy, sleep apnea. What is the differences? Let's, expand upon that for our audience.
Certainly will. Narcolepsy is the inability to stay awake. I mean, you and I can be talking just like we are now, and I just nod off and go to sleep.
I know I can be boring sometimes.
Well, I don't think you're that boring, but it's an uncontrollable episode of sleeping. So
that can be dangerous when you're driving.
Absolutely. There is medication that can treat that.
Okay.
And the way we diagnose that, we do a sleep study the night before just to ensure that some other problems not making the patient real drowsy in the daytime, such as apnea or leg jerks. But narcolepsy, usually what we do is we diagnose that in the daytime. We do what we call nap studies, and we do a series of naps. If the patient, there are several things that indicate the patient may have narcolepsy. One, if they have a history in the family, it is genetically linked.
Oh, interesting.
And also, if they have what we call the tetrad, there's sleep paralysis. That's kind of sometimes, but not always, goes along with narcolepsy. It's where your eyes are awake, but your body won't move no matter how hard you try.
Oh, wow.
Okay.
But you're conscious of that?
Yes. It's a very frightening experience.
I bet.
That's sometimes an indication maybe you might be having narcolepsy. Also, what we call before and after hallucinations, before you go to sleep and after you wake up. They call that hypnopompic, hypnagogic
okay,
hallucination.
easy for you
I don't
to
want to
say.
get too technical in those words, but hallucinations.
So you kind of see things as you're starting to doze off?
Yes, very vivid hallucinations.
Almost like a dream state, but not.
Yeah.
Wow.
So it's
Those are
almost
some scary things. I haven't heard of that before. That
Right.
would be enough to wake you up and make you go, I need help.
right, right. So if you have those, and also rapid REM sleep onset,
Okay.
that's what we look for during the nap studies.
Okay.
If you go into REM, that's rapid eye movement sleep. That's where you have your real vivid dreams.
And your deepest sleep, right? Isn't REM
Deepest sleep.
when you're really resting?
Exactly.
Okay.
And if you go into that, say in less than 5 minutes, there's a problem. Because normally on the average it takes anywhere from 90 to 120 minutes to go into your first REM
For an
period.
average
Yes.
person going to sleep at
So,
night. Okay.
But, we take a really good look at your sleep pattern. We do a sleep diary, and also the medications that the person's on. They can also influence or affect your
Sure.
daytime sleepiness as well.
Okay. So that's pretty cool that you're able to help identify then what the issues are and then help them. So let's talk about this. I know the Sleep Disorder Center, if someone was coming in, have symptoms, whatever, they get a referral, right?
That's
from
correct.
Dr. Matheny or Dr. Malish
Yes.
does referrals. So then they're going to come into the Sleep Disorder Center for the night, correct? So they
Correct.
check in, and what happens? Let's talk about that. What's that
Okay.
experience going to be for them?
Well, even the family physician can refer
Okay,
directly.
it doesn't have to be
But Dr. Malish or Dr. Matheny, one of the two, will look through the charts and make sure that the patient actually does need, in fact, a sleep study.
Okay.
Once that's been approved, then they come to the sleep lab. They come in about 8, 9 o'clock at night.
Okay.
And the technologist will greet them, get them registered in, show them to the room, give them a little educational video to watch.
Oh, okay.
And we also send out in the mail explaining the sleep study, what we'll be doing, so the patient's not totally in the dark
Yeah.
yet until they get here.
Right. Then we shut the lights off on
Yeah.
them, right?
So we put a lot of electrodes on the patient, head to toe, and
Now,
kind of
those
explain.
electrodes they're like sticky things, kind of, right? That go in your
Yes.
head. So
Yeah.
Okay,
The
and
ones
those
on top of the
wires.
head are EEGs. They
Okay.
monitor the brain waves, brain activity, and from that I can tell what stage of sleep the patient's in.
okay.
And make sure when I read the report in the daytime, I can see what percentage of the sleep stages the patient's sleeping in.
Okay.
If they're getting the right amount of that particular sleep stage, REM, stage 1, 2, 3, and 4.
Okay.
Not to get too technical.
Yeah, but there's different stages, and an average person kind of has a average amount in each of those stages.
Exactly.
Okay.
Stage 1 is a very just drifting off to sleep.
Mm-hmm.
It's where alpha is awake. Okay, so you're awake and you go to sleep, and you probably have about 30 seconds of stage 1 as you get drowsy and drift off into what we call stage 2.
Okay.
And it's more beta, and it's even more attenuated brain waves. And stage 2 usually has about 50% of your total sleep time. Okay. And stage 3, what we call delta sleep, usually occurs during the first 1/3 of the night. And as you get older, you get less and less stage 3. It's
Why is that? You don't need it as
Well,
much? Or
You don't. Adolescents get more stage 3 in children because it's where your hormones, growth hormones, are
So your body's
developing.
pretty much telling itself it needs to go into this stage so it can
Right.
replenish or whatever.
exactly.
Okay, that makes
And then
sense.
REM stage, you'll have about 4 to 5 REM cycles during the night. They
Okay.
progressively get longer as the night goes on.
Okay.
And that's why you wake up in the morning, you remember your dreams, because usually the last REM cycle is the longest.
Oh, okay.
it's-
And it's the closest to your wake-up time,
Yes.
kind of? Okay.
And then
okay.
going on down the head, you got electrodes here on each corner of the eye. It monitors the rapid eye movements.
Okay.
So we can tell if you're in just normal, average sleep, non-REM sleep, the eye movements will be slow, rolling movement until you go into REM. And they look like real phasic, sharp eye movements.
Oh, interesting.
And
So
then-
you're not aware, I mean, the sleeper is not consciously aware of that, right? That their eyes are moving?
No.
I mean,
they're
I don't
not.
think I've ever noticed while I'm sleeping that my eyes are moving.
And then we put electrodes on the chin, the genioglossus muscles that monitor the tension of the muscle activity. So we can tell when you're getting relaxed, it just gets thinner and thinner. And then when you go in the REM, your muscles go totally flat, so you won't act out your dreams.
Oh,
so it's
that's
just,
probably a good safety mechanism. Our bodies are pretty amazing what they can
Yes,
do.
they are. Quite amazing. And then we put electrodes on each clavicle here to monitor the rate and rhythm of the heart.
Okay.
And then going on down, we put a belt on the chest, put a belt on the abdomen to monitor the breathing activity, make sure your muscles are in sync with your breathing. Electrodes on the legs for kicking, jerking, twitching. And of course we monitor the oximetry and we monitor breathing. Obviously it's the most important. So,
Right.
So
Okay.
there are a lot of electrodes and sensors. So.
Yeah, I've actually had 2 sleep studies done. First time when I was first diagnosed, and then a few years later to see how I was doing.
Yes,
so.
I remember.
Yep, I sleep with my buddy, my little, I call it my snuffleupagus.
Okay.
It has that long tube.
Yeah.
Anyway, so I do remember all those electrodes, and it actually, I mean, when you first hear about it, you're thinking, I could never sleep with all that stuff on me, but you do.
People do. There are a few select people who have a hard time.
Sure.
But, you know, the sensors, they're designed to be comfortable to the patient.
Yeah.
So really
They're
after a while you don't
just
really
don't
realize they're
notice
on,
them. Yeah.
except to get up and go to the restroom.
Right.
It's not-
Yeah.
Then you
So
realize-
you hook the person up, they go to bed, hopefully sleep through the night, and then when they get up in the morning, you're there to greet them, or someone greets them in the morning, and I know you give them a little continental breakfast kind of thing, and
Right. We make them coffee. So,
okay, yeah,
Yes.
get them up and moving. But I know you also do, or at least in my case, I'm assuming it's fairly normal, like they identified pretty early on in my sleep that I had sleep apnea, so they came and did a couple of different CPAP on me, and hooked me up to see if that made a difference. So is that kind of what you've got there, some of the models of different?
It is, and I'd be glad to show these. When I first started, 18 years ago, there was only like probably one style of mask and one material. It was all plastic. Now today you probably have like 30 different types of masks out there.
Lots of choices.
So I brought a few here to show if a person does have sleep apnea, there are times that, well, let me explain. The patient may not be treated the first night. It all depends. We have certain protocols to meet for insurance purposes.
Okay.
If we go beyond that protocol, we stand a chance of not treating the patient adequately.
Okay.
So sometimes they have to come back a second time.
Okay.
And that depends if they go to sleep right away or what we see. I've seen people roll over on their back and start having apnea, and they don't have it on their side. I've seen them go to sleep at 4 o'clock, and we get them up at 5:30. So insurance requires at least 3 hours of study time on the CPAP.
Okay.
So. But here's one of the masks. It's a full face.
It covers the nose and the mouth.
It does. It does.
Is that for people who sleep with their mouth open?
Yes.
See,
Unfortunately, sometimes you have to go to the full face.
Yeah.
I mean, it's a little bit more mask, or I like to call them nose piece, because mask kind of scares people. But, you know, they do look a little intimidating at first, but after a while you get used to wearing them. So this is the full face. And then we have one that just, for the ones that can just breathe through their nose, we have a nasal mask. Okay, it just fits comfortably over the nose.
Yep.
Yeah. And there's several different varieties and different types of nose
So
nasal
it's kind of
masks.
based on your personal comfort level
does.
kind of thing?
It does. They all deliver the same amount of pressure.
Okay.
And that's another thing I probably want to explain to everyone that, even though they're different types of masks, they all deliver the same amount of pressure.
And when we're talking about pressure, it's blowing air up into your nose?
Right.
Or?
The machine, the nose piece fits, well, the hose fits to the machine, and then the mask fits to the hose, fits over the nose, and it's the pressure. It doesn't pump you up like a balloon like a lot of people think.
But you know what? We're going to take a quick break, and then when we come back, we can talk a little bit more in depth about that. Okay?
Sure.
So we'll be right back after these messages. Stay tuned. Welcome back to Your Health Matters. My guest today is Mark Hopkins from the KRMC Sleep Disorder Center. Thanks again for being on the show, Mark.
Thank you for having me.
Before the break, we were talking about the different headpieces a person would wear, choose to wear, when they have sleep apnea. And we started to talk about the pressure. So let's go into that a little bit more, what that means and what's happening there.
Okay. What happens when we put the CPAP mask on? It creates a pressure inside the throat area.
Okay.
So there can be a lot of things closing off the airway. A lot of people kind of misconstrue apnea to relating it to weight. That's simply not true.
It's not just weight.
Not always.
Okay.
Weight can be a contributing factor because it can push up against your diaphragm and cause you to have air restriction.
Okay.
And then if you have closure in the throat, which is where most of the apnea occurs, it can further complicate it. But,
Okay. So is it more a muscle issue?
It can be muscles. It can actually be the loss of muscle tone in the throat and the tongue area. The tongue can actually fall back and block the airway off.
Okay.
But a lot of times, too, it's the structure inside the soft palate. It can be a narrow palate restricting the amount of air into the airway.
So like if someone has a small mouth?
Correct, inside the throat
See,
area.
that must be my problem. My dentist all the time tells me I have a small mouth. My husband doesn't believe that, but my dentist said so.
Yeah, a soft palate, or a
Okay.
narrow soft palate,
Yeah.
just allowing very little air expanding into the lungs.
Okay.
But also it can be an object in the back of the throat. The tonsils can block off the airway. The uvula, that little meaty thing that hangs down, can fall behind the tongue and block off the airway.
Okay.
Or the arch in the back of the throat can be occluding the airway as well.
Okay.
That's where Dr. Ramirez comes in, the ear, nose, and throat
yeah.
specialist. So.
Okay,
Yeah.
but so that pressure then that's coming in through your nose is pushing whatever it is out of the way.
Exactly. It's splinting the airway open.
Okay.
That pressure splints the airway open so that you can breathe normally.
Okay, very
So
good.
now a lot of times when you're new to CPAP, you feel like it's hard to breathe out, but it's actually that feeling that hard to breathe out, that's the pressure you're breathing against that actually is going to open up the airway as you go to sleep.
Yeah, and you
So,
get used to it. Like I said, I've had mine for, I think, about 6 years now, and
You do.
yeah.
And
Tell
we
me
do
what's
have a
it.
program too there are certain individuals that have a really difficult time having anything on their face. And we do have a program, it's called PAPNAP, where they come in and talk with me, and I go through a series of therapy sessions. It's new to the field.
I was going to say, yeah.
It's brand new to the field. I've been doing it for almost a year. A physician in Albuquerque, New Mexico, created this technique by using relaxation therapy, stimulus therapy,
Okay.
To get the patients accustomed to wearing it. And it's been about 90% effective.
Well, that's
So,
good.
yeah.
So we talked about what caused or can cause sleep apnea. We talked about the different kinds. No, there's one more headpiece there you haven't shown us yet.
Oh, yes. This
want
is
to
the one the ladies like.
Yeah.
So it's even pink. So,
Oh, that's true. That's what I have.
but for the guys, they have the blue strap.
Okay.
But anyway, this is what we call nasal pillows.
Okay.
And it fits
And it just sits
comfortably.
right there?
Yes. Fits right at the base of the nose, what we call the nares. Just very comfortable. It's very soft. And instead of something that sits over the face, over the nose and mouth, or over the nose touching the face, it just fits comfortably at the base of the nose. Called nasal pillows. So it's perhaps probably the number 2 most favored
Very good.
nasal.
And then that hose that you kind of have on the side there, that's what hooks into the other hose that goes to your CPAP machine,
Yes.
right? And that's what pushes the air then.
And if I had an old hose, I could show you the difference between the two. But this one here it's new.
Uh-huh.
And the old hose were really stiff, so when you turned, it'd pull the mask off.
Yeah.
So they've come out with a very flexible hose. You
Very
could turn,
good.
you could
Wow,
do
yes.
alligator rolls, and
Yeah.
barrel rolls.
Very good, yep.
Yeah. So,
So that helps a lot. Very good.
and you can run this however you want. You can run it up over your head. You can just unhook this and let it, hang
Very
down.
good.
And,
Now, we also talked about, I know that there's a mouthpiece that sometimes helps.
Yes.
What's up with that?
It's a dental device. I have it right here. There's several of these. I have one myself I use at home.
Okay.
And it's probably not as effective as CPAP. Statistically, but it's really good for patients that are very mild apnea.
Okay.
And I'm kind of like right there borderline mild.
Okay.
So you put it on at night, it just, they take a mold, and this portion here just sits inside. It brings the jaw forward, and the theory behind it is it will bring that jaw forward. It will slightly open up the airway in the back of the throat.
That airway open. Okay.
So
it's like if you're not severe,
right,
would sleep apnea be an option to help?
And again, I'd like to mention that a lot of things you see on TV, I'd be very cautious.
Breathe more.
Well, those are good. Those
that
are
helps?
good.
Okay.
Yeah, those kind of opens up that cartilage and allows airflow. But these devices you see that put in your mouth are probably nothing simply but bruxism guards, and so be very cautious. There's so many different dental devices out there. I'd suggest going to, if you go this route, go talk to or consult with a dental sleep physician.
Okay.
The only one in Mojave County is Dr. Mark Collins in Fort
Mojave?
Yeah.
Okay, very good.
But
would a sleep study, if they came to the Sleep Disorder Center, that's going to identify the severity of their sleep apnea.
Exactly.
And then from there, then they could maybe look at that option if they...
Right. And then again, that'll be up to either Dr. Malish or Dr. Matheny to refer them further out to someone else, or even perhaps even Dr. Ramirez. They might need intervention in the throat area somewhere.
So that's pretty amazing, all of the different things that can be identified from a night's sleep.
Certainly.
And I've heard that sleep apnea affects many different parts of our health.
Oh, yes.
Someone with sleep apnea can affect your weight.
Yes.
Diabetes. What else?
Yes.
That's heart, I think.
Hypertension. In some cases, yes. I've had 4 people, unfortunately, pass away in their sleep this year.
Oh my gosh.
So they just simply quit breathing, and I think it's not so much that apnea where they quit breathing, but it's the pressure that puts on the heart, and they usually end up having a heart attack or stroke.
Wow.
So yes, it is related to other disease processes. It's linked to obesity. And give you an idea, there's a lot of chemical things going on in the brain.
While we're sleeping?
When you're sleeping, and a lot of chemicals, not to get too technical, but mention 2 or 3 or 4.
Okay.
There's a chemical in the brain called ghrelin.
Okay.
Okay, and when you sleep poorly or don't get enough sleep, it overproduces ghrelin, which tells you you're hungry. So you wake up, I'm hungry.
From the eyes open, first thought, feed me.
And then another leptin. When you don't sleep well, it underproduces leptin, which tells you you're full. So those are 2 bad combinations. You want to get up and you keep wanting to eat because you're never feeling satisfied. So that leads to obesity, obviously.
And that leads to diabetes and heart issues.
Exactly.
Okay.
Cortisol, it increases the amount of cortisol in the body, hormone, and then that's going to have to do with your metabolism breakdown.
Wow.
And then also memory loss, serotonin, stress hormone. So a lot of people with apnea tend to be depressed as well. So it's linked to a lot of disease processes, hypertension. Just about every person with sleep apnea has high blood pressure.
Wow.
So,
and then when you get on the CPAP and you're using it consistently, you're going to see some improvements then, right?
Even in your blood sugar, because it can alter your blood sugar and get it more in line. So if you do treat the sleep apnea, I've heard Dr. Matheny tell the patients many times that you'll want to monitor your blood sugar once you get on CPAP. So
to make sure, because you may have to change your insulin dosage
your
type
dosage,
of thing.
Exactly.
Very good.
Yes.
So what other things does a person need to know about sleep apnea before we wrap up here today? We're almost out of time.
Oh my. There's so many things I could tell the public about sleep apnea, but
why don't we do you have a phone number?
I do.
Okay, what's that?
My number is 928-692-4666. 4144.
4144, 692-4144, and they can call you with questions.
They absolutely can,
Okay.
and I'll be glad to send them information. I have all kinds of, even for
Okay.
children,
Great.
pediatrics.
Okay.
Yep.
Well, thank you for being on the show, Mark. I hope you learned something today. I know I did. We'll see you next week with another great guest.